Hi, everyone. It's really nice to be here today. You guys have done some amazing work and have been very blessed to have Dr. Vitari to do a lot of the groundwork. So hopefully, what we discussed today will be a review. Some of it may be new, but hopefully some of it will be a review as well. I'm just going to share my screen. So just like he said, I am Nikki Gastala in family medicine and addiction medicine, and I got into addiction medicine through the practice-based pathway. So I went to University of Iowa for residency and worked in a critical access hospital system when I graduated in rural Iowa. And from there, I found quite a bit of substance use disorders. And because we were a critical access hospital and FQHC system in a rural area, there was very little access to treatment. And so our sort of motto for our FQHC was that we really need to meet the community needs. And so we ended up starting a integrated addiction and behavioral health program within our primary care setting, and then expanded that to the hospital system as well as the local jail system, Marshalltown County Jail. I grew up in Chicago in the South Side, so I came back with my husband after he graduated from fellowship and have been lucky enough to work at UIC at their FQHC system called Mile Square. We have 13 different health centers in some of the most sort of underserved areas of the city. The majority of our patients are about 200% below the poverty level, and we really focus on underserved communities, particularly those of color. Most of our patients are Latinx or Black, and the opioid epidemic has really impacted them significantly. If you look sort of at the overall history of the opioid epidemic, or what you see in the news, a lot of the highlights have been on sort of that rural or suburban white, young individual. But the reality in Cook County and the city of Chicago is that the majority of patients with opioid use disorder who are dying are actually African American men in their 50s, 60s, and 70s. And the opioid epidemic in the city of Chicago is old. It's been here for decades, but really hasn't gotten the access or treatment or highlights that the rest of the country has because of, again, a lot of the inequity that we see in medicine. And so I'm hoping today that we will be able to sort of go through the importance of universal screening and treatment of opioid use disorder in hospital systems, because this can have a really big impact. So one of the, I think, most important statistics to really understand is that if you have a patient that presents to the ED or hospital and they present following an overdose, an opioid overdose, they have a higher chance of dying within the next year than a patient who presents with a heart attack. So in terms of morbidity and mortality, our patients with opioid use disorder have a very high mortality rate in that first year, which really gets to the point of why we should be screening, why we should be doing more in the hospital system, and why we should be integrating addiction services as part of our ED encounters, our inpatient for EM, IM, family med, and OB-GYN, just because it's really hard to not, it's really unethical not to address, and really it's becoming standard of care to address it. So we'll talk a little bit about, so the opioid epidemic has really been very significant in terms of its financial impact, in terms of the number of individuals who do have opioid use disorder, and whether that's painkillers or heroin or fentanyl related. That opioid overdoses caused 46,000 deaths nationwide in 2018, and this exceeded the number of motor vehicle accidents. And this is sort of where that epidemic, and we got into the media where that sort of came into play. About 2 million people in the U.S. ages 12 and older have OUD involving prescription opioids, heroin, or both. And opioid-related emergency department visits more than doubled between 2005 and 2016. And I know you guys see that there. I mean, your ED and inpatient, you have a very big hospital. You guys took care of my stepdad. He had a heart attack and need a quadruple bypass, and you guys did an amazing job, so thank you. He's doing very well after that, but I got to visit your hospital several days in a row, and I know the amount of patients that you see. We know that opioid-related inpatient hospital stays increased about 117% nationally, and this could be directly from respiratory depression from the impact of an opioid overdose, but can also be secondary to the complications of opioid use disorder, right? Endocarditis, osteomyelitis, cellulitis, all of these have a really big impact and contribute to hospitalizations. When you look at the opioid sort of epidemic, there's really sort of three phases or three waves that it has come in. One is the prescription opioid overdose deaths, which is what sort of was first highlighted. The second was the rise in heroin overdose deaths. And then lastly, the rise in synthetic opioid overdose deaths, meaning fentanyl, particularly illicitly manufactured fentanyl, because it is so potent and very cheap to make. Is why it's so readily available. So why have a hospital-based addiction services? Why treat patients there? Well, patients present to the ED on average 9 times prior to an overdose hit, so that's 9 missed opportunities, right? Patients with OUD are frequently hospitalized with complications of their condition and yet don't receive treatment. And really many patients leave AMA, right? So you have patients, if they have opioid use disorder and you're admitting them for osteomyelitis and they need several weeks of antibiotic treatment, if you don't treat their withdrawals, if you don't stabilize them, they will leave against medical advice because of how horrible they feel in terms of the vomiting, the diarrhea, the pain that they experience. It's natural and human, right, to not want to feel pain and not want to feel sick. And so we need to recognize that in our patients and that it's their human right to get treated for this as well. And so they'll leave, and many patients do not do well. They'll either return to you for an admission, return to you in much worse condition, or die outside the hospital. And really, these hospitalizations can be an ideal opportunity to start effective medication treatment for addiction and connect patients to ongoing outpatient services. Many patients have a terrible experience with the medical system if they have addiction. They've been mistreated. They've been not treated well in terms of compassion and empathy, right? They've been marginalized. And in some instances, really stigmatized for what they do, looking at their health condition as a moral failing, right? Sort of like what happened with the HIV and AIDS epidemic about a decade or two ago. This is what we see in how patients are treated in our healthcare system. So it's no wonder why they don't want to seek services sometimes. So this is a new opportunity to be able to connect to patients, to assess their readiness for change, to help them in their recovery. And it can be probably one of the most rewarding experiences you can have as a physician, honestly, because you can help a patient turn their whole life around. You can treat diabetes until your face is blue, but the reality is many patients you're not going to be able to pull back that time. Patients with addiction, you can really help stabilize them and prevent them from dying and help them regain their life, their relationships, employment, and it's pretty significant, the impact you can have. So this sort of, again, goes into explaining the importance. It really will impact your hospital readmission rates. It will impact the length of stay for patients and quality outcomes that you have. And Medicare and Medicaid may not repay for those readmissions based off of if it's the same diagnosis. We know that when patients are being treated with buprenorphine or methadone when they are hospitalized, these medications are often discontinued. And this increases their risk of relapse, increases their risk of overdose and death. So it's really important. There's a great article that said that's why we do things in medicine for no reason. And one of these articles is about why that you should never discontinue a patient's medications for opioid use disorder during an admission or during a surgery, unless there's a real good reason to. It shouldn't just be arbitrarily stopped like you stop metformin when a patient comes in the hospital. It has a significant cost for the hospital in terms of increased medical and surgical complexity. You get poorer outcomes, as I said, increased length of stay, and increased 30-day readmission rates. So while addiction treatment does not generally produce high revenue streams, screening and intervention can produce better clinical outcomes, and this reduces costs for the hospital overall. And savings can be as powerful as revenue. So when you look into the legality, this is one of the questions that we get all the time about can you treat someone for substance use disorder, particularly opioid use disorder, with methadone or buprenorphine while they're hospitalized? The answer is yes. So if a patient is admitted to for a medical or surgical reason other than addiction, so addiction isn't their only diagnosis, methadone and buprenorphine can be administered to maintain or detoxify during their entire hospitalization. No time limitations, including new starts. So if you have that patient you're admitting for osteomyelitis or endocarditis who needs 7 to 12 weeks of IV antibiotics, you can start them on methadone and titrate them up. Just make sure that as soon as you start methadone, you contact a treatment program that the patient will then follow up at when they're discharged. And you can titrate them slowly up during their whole hospitalization. Same thing with buprenorphine. You do not need an X waiver to dispense buprenorphine in the hospital. The 72-hour rule, which is what many people discuss when they say, oh, we can't do that during inpatient. The 72-hour rule means that you can treat someone for addiction with medications if that is their only reason for admission, or if they're coming back for 3 days in a row to your ED to get dispensed medication because of a timing issue. So it's really important to sort of understand that if a patient is admitted for a medical diagnosis, that you can start and maintain them for as long as they're admitted for. If it's just addiction that you're admitting them for, then that's when the 72-hour rule comes into play. So how do you help a patient decide? Well, there are 3 FDA-approved medications for opioid use disorder. You have methadone, buprenorphine, and naltrexone. Methadone is a full agonist. In most methadone clinics, it's a liquid that you drink. You don't have to be in withdrawal when you start it. In general, you do have to go to, when you're discharged, go to a dedicated clinic called an opioid treatment program and be seen 6 days a week. And then they will, dose you during that time. In terms of efficacy, it's about 74 to 80% effective, and it really reduces risk of overdose and death. So really important option. The only thing you want to consider for patients on methadone is that you're starting on methadone is that you start low, go slow, and titrate appropriately, and we'll talk about different protocols that you have. Want to get an EKG as well to test for QTC prolongation. Methadone is a little bit of a dirty medication. It is metabolized by the liver and the SIP system. There's a lot of medications that interact with it in terms of increasing metabolism or decreasing metabolism. So just some things to be aware of with that medication. But we do use methadone in other realms, right? You use it in palliative, you use it in onc. The dosing structure is a little bit different because it's for pain, right? 2 or 3 times a day. Methadone for opioid use disorders only needs to be dosed once a day. Buprenorphine is another great medication. This is a partial agonist, so it binds to the opioid receptor but doesn't fully activate it. One of the great things about buprenorphine is that it has a ceiling effect, so patients don't overdose on that medication. It has a ceiling effect for respiratory suppression. It doesn't impact cognition, which is a really big deal if you have, patients who have been impacted by methadone, who feel foggy on methadone. They won't get that on buprenorphine. It's great for elderly. It doesn't increase risk of falls. The nice thing is it can be prescribed as long as you have an X waiver. If you don't know, the X waiver rules changed recently. As long as you have a state license and a DEA, you can go on the SAMHSA website and complete a notification of intent, and you can treat and prescribe up to 30 patients at a time without having to undergo the 8-hour or 24-hour training requirements that used to exist. That came out at the end of April by HHS. So this is a medication that you can prescribe. You can give it in the hospital. It's generally given once or twice daily. It helps with cravings and withdrawal. It's about 60 to 90% effective. The only important thing is when you start this, you want to make sure that they are in moderate withdrawal, a CAL score of 7 or higher, so that you don't precipitate a withdrawal. Because it is a partial agonist, it will kick off any pure agonist off the receptor. So it'll kick off fentanyl, it'll kick off heroin, it'll kick off oxy. So you want to make sure that they're in, that there's enough receptors free for it to bind, and then the patient should see an improvement in their withdrawal and craving. Now, Trekzone is the last medication. This one we generally don't start in the hospital system. Patients have to be not using opioids or off opioids for 7 to 10 days, and then you would start the injectable naltrexone. This is not as effective. Only about 10 to 21% of patients stay in treatment after a year. With this, it has not been shown to reduce risk of overdose or death. If they miss a dose of this, their overdose risk increases substantially because it's as if they're opioid naive. So that's really important to discuss with patients. So the biggest thing is 7 to 10 days without being off opioids. They have to get the injection every month. Retention's not as good and doesn't really impact morbidity and mortality. So you're thinking, like, when would you want to use this? Well, it's really good if they've got opioid use disorder and alcohol use disorder because it helps with cravings for both. Or if they're, in a job that doesn't allow them to be on methadone or buprenorphine. But a patient has to be really engaged and really understand this medication in order for it to be the right one for them. And always make sure that you dispense or prescribe naloxone when they leave the hospital or the ED. It's a life-saving medication. So how do you decide in terms of your own knowledge about which one you want to do? So I use that handout with patients because it's really important that they have ownership of which medication they want and they understand the pros and cons of each. You want your patient to be a partner in their treatment plan because the only medication that is going to work is the one that they're going to take. For your knowledge, what about outcomes? What does the data show us? Well, we know that buprenorphine and methadone are pretty equal in terms of efficacy for retention and treatment, reduced illicit opioid use, overdose deaths, all-cause mortality, and reduced HIV risk behaviors. Now, Trekzone has only been shown to increase treatment retention and reduce illicit opioid use. It has not been shown to increase or to impact the other areas. When you look at retention and treatment at 12 months with reduced illicit drug use, abstinence-only models do not work. Detox does not work. You have about a 6% efficacy or retention and treatment at 12 months, which is pretty low with behavioral therapy without medication. Now, Trekzone between 10 and 31%, buprenorphine 60 to 90, and methadone between 74 and 80%. So it's important to sort of understand that whole idea that opioid use disorder is best treated with 12 steps or NA and abstinence. is not going to work for most patients. So what are the key steps to having a successful hospital program? Well, doing universal screening, treatment of opioid use disorder with medications by a clinician in the ED or during their hospital stay, adopting hospital protocols and guidelines for induction and maintenance, dispensing or prescribing naloxone to reduce opioid overdose mortality, and then connecting patients to outpatient treatment programs for continued medication and therapy management on discharge. So as soon as you put in that order for buprenorphine or so you've diagnosed them with OUDs, the DSM-5 criteria, they meet criteria, you discuss the medication options, they tell you, I want buprenorphine or I want methadone, and you're about to go in your EMR and write in the prescription, at that time it should signal to you to say, okay, I need to talk with our social work team member to make sure that that patient starts the process of getting connected to an outpatient treatment center if we are not able to see them in follow-up. I know you guys are going to be building a pretty robust buprenorphine treatment program as on the outpatient side, so that part will be easy. But then if you're going to start methadone, if you don't have a treatment center that you work with, you're going to want to have one so that you can send that patient and coordinate that care. Because you cannot prescribe methadone at discharge. If you have your X waiver, you can prescribe buprenorphine at discharge to get them to their follow-up appointment, but you cannot prescribe methadone when they leave the hospital. So here's an example of evidence-based hospital guidelines for methadone and buprenorphine. So on the left side, this is from the California Bridge program. This is an SAMHSA SOR funded. It's completely free. You can use them. We adapted them for our hospital system at UIC. So if a patient has opioid use disorder and they're ready to start methadone, they say yes. And that's the one they choose. If there's no sedation, then you can give them between 10 and 30 milligrams. How do you decide? You can decide based off of their risk factors and how much they use, right? If they've got terrible COPD, I'd probably start a little bit lower. If they're generally otherwise pretty healthy except for this osteomyelitis or cellulitis that they're admitted for, then you could probably start at 30. You recheck them after about 4 hours. Are they still having withdrawal or cravings? Because that's when methadone, you really start to see the peak is around 4 to 6 hours. If there's no sedation and they're still having withdrawal symptoms, then you can give them another 5 to 10. On days 2 and 3, you give them, if there's no sedation given, you give them the total dose from the prior 24 hours. So say you gave them 40 on the first day, then on the second day you give them 40 and you reassess them in 4 hours. If they're still having withdrawal and cravings on that day 2 and day 3, you check a Ramsey score. If it's less than 2, you can give, and they're still saying they have cravings, you can increase by 5 or 10. The max amount you want to give on day 1 is 40, on day 2 is 50, and on day 3 is 60. Whatever dose you get to after day 3, you hold for 5 days. You can increase by 10 milligrams every 5 days, but do not increase more than that because of the way that methadone works. It builds on itself, and you will get a very sedated patient on day 5 if you don't stop this dosing. Just remember, again, methadone cannot be prescribed. So once they leave your hospital, they need to be set up that day or the next day with an OTP, with a methadone clinic, and make sure you give them naloxone when they leave. So it's pretty easy, right? Like, that is not a hard protocol. I think titrating insulin is harder than that, right? Like, all of the, X glucose and give X, units of insulin and recheck and X amount of time. That's way more complex than this. So that's the methadone. For buprenorphine, if they're in uncomplicated opioid withdrawal, so meaning that their CAL score is 7 or higher, make sure they don't have any opioids in their chart, right, that are being, don't start them on any. Administer 8 milligrams of buprenorphine sublingually, wait an hour. If the withdrawal symptoms improved, then give them a second dose. You can give them 8 milligrams up to 16. In the ED, you can give up to 24 milligrams, and that will give them a higher loading dose if you need to get them through a day or two. If you have your X-flavor 16 is usually the good dose to impact and suppress cravings. So give them 16 milligrams per day until their follow-up appointment. If you don't have your X-flavor, load them up to 32 milligrams for a longer effect, and that way they can get, if it's like Friday night at 3 a.m., that'll get them till Monday morning. And then make sure again that they have a naloxone kit and you've done overdose education. If the withdrawal symptoms don't improve when you first give them Suboxone, then you got to ask, one, did you precipitate a withdrawal? Were they not in complete withdrawal yet? Were they having any side effects of the buprenorphine? And then sort of work through that process. You can usually, it resolves on its own. You just need to, wait and then give them more bup and they'll feel better. But it's also okay to stop if they're not feeling well. But that's why you want them to be in withdrawal when you start it. So what about naloxone? Why is this so important and why are we pushing so hard for this? Well, we know that it doesn't increase drug use. It actually increases drug treatment. It's cost effective. It reduces overdose deaths, and it should really center around people who use drugs. There's no other indication for it. It's not going to harm anyone, and is extremely successful and impactful for reducing death. So let's talk a little bit about an example site who did something like this. So we're going to talk about Rush. So what they did was they sort of focused on 4 different levels in terms of patient care, education and teaching, quality of care, and then research. They have a big research component. But the patient care, they focused on comprehensive treatment, naloxone training and education, dual diagnosis treatment, rapid follow-up, reducing stigma and bias in the ED and inpatient side, ED methadone linkage, and community partnerships on the west side, because that's where many of their patients come from. Making sure that med students and residents were comfortable in understanding and training, and then doing grand rounds and presentations and lectures like this, as well as providing X-flavor training. They also focus on quality of care, working on early interventions, improving protocols for SUD management in the hospital, creating an interdisciplinary care team, and then making sure that they use evidence-based tools and disseminate the information that they've learned to other centers, which is why we're using their slides. So when they were funded to do this, they're still doing this program, and this is their data from 2018 to 2019. They did universal screening. So they admit about 35,000 patients per year, and they screened anywhere between 26 and 30,000, which is pretty good if you think about it. That's a lot of people. Those who are positive, their universal screening is twofold. One, alcohol misuse in the past year, or drug misuse in the past year, and this was done by the nurse during admission. Secondary screening was patients who were positive who needed a secondary screening, and they received the audit and DAST. If they were positive, then they received what was called a brief intervention by a social work team member, meaning that there was some motivational interviewing, seeing are they ready to change, any of those things. If they were, then that would trigger a consult to their addiction service, who would then come down and do evaluation, treatment planning, and linkages to care. Those who had opioid use disorder, of course, are a smaller amount, who are interested in starting on buprenorphine were then started during their hospitalizations. And what were the outcomes? So this is the number of appointments that were scheduled. Those who completed the outpatient appointments were about, upwards of 60%, which is pretty good. Those who went to the MAT and psychiatry appointments, about 50%. about 50, little in the 40s, completed therapy appointments, and of those who ended up going on to do outpatient inductions who had not done that on the inpatient side. So what were the actual outcomes in terms of quality improvement? So those patients who had a consult who have substance use disorder as a secondary diagnosis, right? Remember, it's a medical center. They're only admitting for medical reasons, and SUD is a secondary diagnosis. Those who had the addiction service consulted, their length of stay was 5.77 days compared to no consult, which is 6.54. So there was that increased length of stay for those patients with substance use disorders who did not get a consultation. And if you look at the cost difference with SUD as a secondary diagnosis in terms of cost analysis, the cost savings for those patients who had the addiction consult versus those who did not was about $1 million, which was more than enough to continue funding their service. So what, do we need a whole program to improve outcomes? I mean, I just showed you sort of the Cadillac, right, of what could a whole sort of system change look like? That's very hard to get to and takes many years, to build something of that capacity. And the reality is no, you don't need that whole thing in order to have an impact on the patient in front of you, in order to impact the patients in your community and the patients you see in clinic. There are cost-neutral components, right, that don't cost anything. Utilizing screening within your EMR, not building something new, but just using screening tools that are already there and just working it in as part of your admissions process, right? Whether it's one of the nursing questions that it's asked or it's the resident asked it during the admission, just integrating screening will help you, is a big step to identification and doesn't really cost anything extra. Co-prescribing naloxone, this decreases readmissions and it decreases overdose deaths. It's not a big extra financial challenge. Methadone or buprenorphine initiation and stabilization with referral to outside partner. If you see a patient in front of you and you're doing the admission and you diagnose them with opioid use disorder, offering them these medications is not going to, you don't need a whole consult service to do this. I showed you two very simple workflows. These are not complicated medications to deal with. You all deal with much more complex medical problems in the hospital, right? So it's important to include this as one of the priorities on your assessment and plan and diagnoses and appropriately treat it as if you were to find diabetes or anemia or something else during an admission that you have. And it'll really decrease the patients leaving AMA, which really impacts, again, readmission rates and outcomes, and also will also positively impact that patient's life and also positively impact that team the medical team is taking care of. Doesn't feel good when a patient leaves the hospital and has not completed their care. You can train internal medicine, EM, FM to treat opioid use disorder like any other chronic condition. So holding grand rounds like this, integrating workflows and processes, setting it as an expectation by the faculty that this is something that we treat just like we treat any other chronic condition that for a patient that is admitted to our service. You don't need any additional staff or consult service really to do that. So universal screening can really help identify patients that benefit from hospital-based interventions. Combining screening and dedicated discharge clinic can reduce length of stay and improve care in the discharge clinic. Whichever community partner, whether it's your own clinic or community partner, can really impact that patient's outcomes. Savings produced can cover the cost if you were interested in developing a service. And if you work in a very small center or multiple centers, teleconsultation can also be a pretty viable approach to support those health systems. Ileana and Nikki will you'll be able to get access to this zip drive, which has some great resources in terms of protocols, toolkits, research reports, and additional resources that can help you sort of integrate this as part of your practice. And that's it.
Thank you so much, Dr. Gastala. That was very, very insightful. I think two comments from me. This is Chad Moriali, one of the chief residents. I found it quite striking that patients that are admitted to the hospital with opiate use disorder that goes untreated have a six-fold higher risk of mortality. Is that correct?
So those patients who are admitted, or those patients who present to the hospital with an opioid use disorder that go untreated after they've survived an overdose have a higher mortality risk than those who survive a heart attack. Like, so if two patients walked in and one had a heart attack and one presented after an overdose, the patient with an overdose has a 6 times higher mortality rate than the one who you saw for the heart attack. And on average, patients present to the ED 9 times prior to dying. So it's sort of like 9 missed opportunities that we have.
Great, thank you for that. One question I had for you is, when we're rounding, I always find it that the patient that comes in that's on methadone always comes in on a Friday or a weekend, and it's always difficult to call their clinic to get their dose, to confirm their doses. For someone that you're newly starting on methadone or buprenorphine, is there any advantage to using methadone over buprenorphine? Because I feel like from a physician point of view, if you have the training, if you have an ex-waiver or a colleague that is knowledgeable in the space, it seems like there's a lower threshold to start treatment with buprenorphine than methadone.
Yeah, so I would always defer to what the patient wants, because what the patient is willing to take is the one that's going to be most effective. If you start with buprenorphine in the hospital and that's not what they want, they will not continue it when they leave. So that's the first step. So I would explain both of the medications. Sometimes people don't want to do methadone because you do have to go to an OTP once they leave the hospital 6 days a week to get dispensed for the first 90 days, and that's a federal regulation that must be followed. So there's really no way around that unless there's an exception based off of health, like dialysis or something like that, or they're undergoing cancer treatment or something like that, right? And that can be really hard depending on where the patient lives and do they have access. Because if they live an hour away from the closest methadone clinic, they're not going to be able to do that on a regular basis. For buprenorphine is much easier to start and maintain because of the X waiver, because many of us are able to do it on the outpatient side. So yes, in terms of ease for the physician, ease for the health system, it is much easier. Methadone, as you saw, you still have to start low and titrate. And the reality is that patient who is admitted who uses 10 bags of fentanyl or heroin per day is not going to be controlled. They're not going to feel controlled with just 30 milligrams. But you cannot really increase beyond 40 milligrams on that first day because of the way the pharmacology of methadone. The reality is in the outpatient setting, most patients who start methadone continue to use for the first, couple months intermittently as you're titrating their methadone dose. They can't do that when they're on the inpatient side. So you have to aggressively treat their withdrawal symptoms. They'll get some impact from the methadone, but they're not going to get all of it that you would get with buprenorphine, right? Buprenorphine is going to resolve your withdrawal symptoms that first day. Methadone will not do that. It'll take a few weeks to get there. So you have to aggressively treat them with Zofran, clonidine, loperamide, gabapentin, all of those things. So that's an honest conversation I have with patients. And I say, like, look, like, you may not get, during this hospitalization, you may want methadone, but we're going to have to aggressively treat withdrawal because you won't be able to continue to use. You may not get the same level of comfort that you would want to have, right? And again, it's human nature. That's very natural not to want to feel sick, right? And we need to understand that and respect that. But giving them that education and allowing them to make that choice, many of the patients may and do pick buprenorphine because of that. Does that help?
Mm-hmm.
Yeah, that was fantastic. Thank you so much. I think we have one question here in the audience from Dr. Gordon, who is taking the lead on starting a opiate use disorder clinic here at Christ. Just flip it on.
How are you? I had a couple questions, but one of the questions that I had, how do you handle a patient that possibly comes in over the weekend, possibly pregnant, going through withdrawals,
Yep.
and say they go to the OBGYN and they get started on like Norco because that's typically how they would handle treating those withdrawals. That might be what they're used to doing. And then when they talk, you have this conversation to them about opioid use disorder and that buprenorphine might be a better choice, or they want to switch them over. And you talk to them that if they want to do that, it has to have this whole induction type of process. But then you also get concerned because if they go through this withdrawal process, it could be dangerous to the baby.
Yep.
So how do you do this if they've been on something like a Norco every 4 hours for a long period of time, but they want to switch them over to Subutex or something like that? Have you had that kind of interaction with opioids and then switching over to Suboxone, not wanting to hurt the baby, but having to do an induction? With Suboxone, you can feel that in right away.
Yeah, absolutely. So in pregnancy, they can be in mild withdrawal. You don't want them to go through severe withdrawal. So you want them into sort of mild to moderate withdrawal. We always offer first, remember you've got that 72-hour rule, right? So you can, we at UIC have created a hospital guideline where we admit or to like observation, like our pregnant or OB floor, not labor and delivery, but you know what I mean, the observation area of L&D, we'll admit them there and for an induction on either methadone or buprenorphine, whichever they choose. And we just monitor them and do it at the same time. We created a hospital guideline for that. So that's what we offer first to patients. If they absolutely do not want to do that, we discuss with them the risks of doing home induction with buprenorphine, or we do offer an office induction and see which one they want to do. You can be, again, mild to moderate. You want their CAL score a little bit lower. And it's actually easier with Norco, especially prescribed Norco, because you know exactly what they're on. It's much harder when it's street drugs because you don't know what's always in there. It can be contaminated with methadone or fentanyl or all kinds of things. So it's actually easier when they're prescribed Norco. You could also do a micro-induction protocol with them where they continue to take the Norco for a period of time and do little tiny doses of buprenorphine and very slowly titrate them up as you titrate them off Norco, and then they never have to go through withdrawal at all. So that's another option if the patient's really engaged and able to follow, close instructions, which includes like cutting a strip into a quarter and taking it. Like that is what they would have to do. But that's very effective, and we've done that quite a bit with our chronic pain patients. So there's definitely different options you have. And then just document what the patient, some patients are, for sure, they're okay getting admitted and do observation, and you can, check fetal heart tones and all that, during the process every couple hours, blood pressure, all of that. But some patients, may have other kids at home and cannot do that. And so working with them.
So I think in this particular instance, it's the providers that aren't comfortable doing the Suboxone. So they themselves started the opioids like Norcos and things like that, where the patient wanted Subutex because that's what they were on before getting admitted. And so then when we decide to start the Subutex, they've already been on. So we do something like the Burmese method, or try to walk them through the Burmese, the microdosing method. But they just don't feel comfortable because they'll push them into precipitated withdrawal because they don't quite know how to do the CALs appropriately, or the anxiety is getting counted subjectively as opposed to more objectively. And so they'll push them into withdrawal a little bit more. But I agree, maybe developing a protocol or some type of guideline along with those providers and making them a little bit more comfortable.
Yeah, that's been really, really helpful. And then pushing more of the objective measures as part of the withdrawal rather than the subjective. Because like stomach cramping and anxiety are, you know, being in the hospital, I'm anxious, like if I was being admitted, right? Like that's going to feel terrible. You know, all kinds of things happen to your body during pregnancy, right, that may affect your GI system. So you want to try to stick with as many of those like objective findings as you can. It's hard to, you know, make your pupils undilate, right? Like that sort of thing, or the runny nose, like that's very apparent when they get into that more moderate, or the piloerection, right? The goosebumps, they can't really falsify that, or like stress won't increase that. So those are sort of good markers to take a look at.
Honey, that water is filthy. Let me dump it on the flowers.
And then, you know, we are trying to work with the residents and teach them about using buprenorphine on the inpatient side and things like that. Can you talk to times where it would be maybe appropriate to stop buprenorphine on the inpatient side? So if a person, let's say they have really chronic medical conditions, or let's say they're getting transferred out of an intensive care unit, or they're on like high oxygen levels, or they have, you know, respiratory issues and things like that. At what point would you hold buprenorphine or things like that? At what points would you say, you know what, maybe we should just hold this and treat the withdrawal symptoms really aggressively with symptomatic management until it's appropriate to restart it?
With buprenorphine, hardly ever, because it doesn't cause respiratory suppression. The only thing is if someone is in uncontrollable pain and you're having a hard time controlling their pain, you may want to decrease their dose. So you can decrease it to below 8 milligrams is when you start to get the opioid blockade effect. So you could decrease it to 4 milligrams and still keep it on board, so that, and then treat with them with opioids for their, you know, pain or ketamine or whatever. And then once you peel those back, increase the Suboxone back up, but then you don't have to do a reinduction for them. But buprenorphine doesn't really have any drug-drug interactions. It's safe to use on dialysis or in, you know, severe renal. The only time I would say is that I would ever stop someone is if they came in with acute hepatitis. That is the only time that, like, severe acute hepatitis with AST, ALT, like in the thousands, that's when I would talk to the patient about considering holding it until like that has resolved. But in terms of ICU, respiratory suppression, surgery, any of those, I would, you know, not really, I wouldn't hold it. Methadone's different. Methadone, if someone has respiratory suppression, you know, that is, or they're severely respiratorily compromised, that would definitely be a different story. But you would definitely want to consider holding that and using other short-acting opioids and aggressively treating their withdrawal, or if they've got really prolonged QTC or have get torsades or something, that's definitely a time that I would do that. But for buprenorphine, again, because it has very minimal drug-drug interaction, it doesn't have respiratory suppression, only really fulminant hepatitis is what I would stop it for.
I think we have one question from one of our faculty members, Dr. Saeed, who's on Zoom. Dr. Saeed, if you want to unmute and ask your question, you're welcome to do so.
Sure, thanks. This is great, really helpful information for us. We're working on getting better at this, and Dr. Gordon's leading that charge, which is awesome. Just one, I don't know if this is really a question, I guess, but I just want to make sure for the residents on the call that when we're talking about buprenorphine doesn't cause respiratory depression, that's in opioid tolerant patients. If you have a, I just want to make sure we're very clear. If it's an opioid naive patient, it can still, right? I mean, that partial agonist effect can still cause a problem.
Yeah. So if they're opioid, so it's only been seen in overdose alone in children, for opioid naive children. You can get some respiratory suppression in opioid naive adults, but it's not usually enough for an intervention, but it can happen. So if they are opioid naive, you'd want to start lower and titrate up. So, 2 or 4 milligrams and then titrate. So say, and you're thinking like, why would you ever start this in someone who's opioid naive? There are actually several reasons you would. If someone's been justice involved, and they return to the community and they are having, they have a history of opioid use disorder. They weren't treated during when they were in jail, but now they've returned and they're around their community and they're having intense cravings because of in their environment again. That is a patient that I would start on buprenorphine, and who's opioid naive. I would just start, a little bit lower, 2 or 4 milligrams, and titrate up to an opioid. To where their cravings are controlled. But in terms of overdose, they're very unlikely to cause an overdose, even in an opioid naive adults. It's mainly kids.
Thank you. Great answer.
Yeah. It's a really good question. Good point. Well, I really want to thank you so much for having me. I'm going to put my email address in the chat. So I'm also the medical director for SUPER, which is the Substance Use Prevention and Recovery Division of IDHS. So if you ever want help, like technical assistance, whatever it may be, please reach out. That's part of what we do. And we'd be more than happy to come out if there's any questions regarding regulatory or anything that you can possibly think of. Just let us know.
Great. Thank you so much, Dr. Gastala. That was very, very insightful, and we really appreciate your time and expertise in educating us. Thank you so much.
You're welcome. Have a great day.